Hello once again and welcome to our series of online classes, Season 2, where we are focusing on the application of pharmacology sa nursing practice. Once again, my name is Jonas and I'm your lecturer here on Class Kirby. If you're new to the channel, kindly hit the like and subscribe button so that we will be able to notify you every single time we're posting new contents. Without further ado, let's proceed to our topic today, which is the reproductive pharmacology, where we are to talk about drugs associated with the female reproductive cycle. For this discussion, we would be focusing on four objectives. Number one, we would like to understand the physiologic changes that happens among our pregnant clients. Number two, we would like to identify the commonly used drugs during pregnancy, even at the time of labor and after the time of delivery, or what you call your postpartum stages. Number three, we would like to gain comprehension in terms of action of these different drugs involved in your reproductive system. And number four, we should categorize the different drugs used during pregnancy, labor, and delivery, as well as postpartum changes. So what exactly are the physiologic changes that happens among our pregnant clients that might alter the whole pharmacokinetic and pharmacodynamic phases of a particular medication? Number one, you need to understand that in order to maintain pregnancy, continuous elevation of your progesterone is needed, which is steroidal in nature. That's why, number one will be the influence of circulating steroid hormones on the liver's metabolism of drugs. I would like you to understand that this presence of different hormones within your body also alters the function of your liver. And having the knowledge based from our discussion on handout number 1, alteration in the function of your liver equals alteration in your metabolic processes. Number 2, due to the increased blood flow within the body, primarily because of the existence of another fellow down there in the mother's uterus, blood flow is generally increased. Having that said, you know that the concept that if blood flow increases, there will be a direct relation increasing the rate of all the pharmacokinetic phases. That will include absorption, distribution, metabolism, as well as excretion, which in this case, there will be an increased glomerular filtration rate and renal perfusion. Ergo, the excretion of the drugs is also being increased. Number 3, dilution of drugs, primarily because there is an increased maternal circulation. Dumagdag ang blood volume, ang body fluid. Therefore, your medication that is simply diluted for 6 liters of blood, might now be diluted in 6.5 liters of blood. Basically, the drug serum concentration is being lowered. Number 4, changes in the actual drug clearance due particularly on the latter portion of pregnancy, resulting to a decreased drug serum level and tissue concentration of that particular drug. Generally speaking, it might require you to increase your dosage a little bit in order for the female client to have the same effect. Another thing that is important to consider among our pregnant clients is the existence of what you call placenta. Okay? Your placenta allows substances to transfer quickly or slowly between the mother and the fetus depending on variable factors, which are the following. Number 1, syempre, blood flow. If there will be an increased blood flow between the placenta and the mother or maternal circulation, then you can safely say that medications are also being delivered faster there. However, there are other factors to consider as well. Number 2 will be molecular weight. General principle, the smaller a particle is or a substance is, the faster it passes through a semi-permeable layer, which in our case now is your placenta. Mas maliit, mas magaan, mas mabilis pumapasok. Number 3 will be the degree of ionization. Based from our discussion, module number 1 again, if a medication is highly ionized, naiiba, ibig sabihin, mas mahirap na pumapasok ang gamot sa ating placental barrier. On the other hand, medications that are non-ionized easily passes the placental barrier. Next is the degree of protein binding of a particular medication. Highly protein-bound medication does not cross the placenta, primarily because of the existence of a large protein molecule, which makes, well, the whole compound large, unable to pass through that semi-permeable layer. Number 5 is the metabolic activity of the placenta. Because the placenta has the ability to biotransform molecules into active metabolites that can affect the fetus. That's why it's a special consideration if a client is pregnant. Kaya palaging tinatanong, are you pregnant? When was your last menstrual period? Are you suspecting of any pregnancy? Because those are special consideration for different pharmacologic reactions towards a particular drug. This point allow me to classify drugs according to their pregnancy risks. When you are reviewing different medication, particularly when you are preparing your drug review or drug outputs, okay, you are encountering words such as pregnancy risk categories A, B, C, D, and X. So what exactly does these letters imply or these categories imply? Let's start with category A. When we talk about category A, simple lang. Enough ang studies, walang side effects sa fetus. Adequate and well-controlled studies have failed to demonstrate risk for fetal delivery in the first trimester, and there is no evidence of any risk even up until the latter portion of the pregnancy. That's why pregnancy risk category A is considered to be okay. Pregnancy risk category B. Animal reproduction studies have failed to demonstrate risk for fetal or fetus development. However, there are no researches or adequate studies and well-controlled studies among pregnant women. Ibig sabihin sa mga hayop na patunayan, walang effect sa fetus. However, among Homo sapiens sapiens, meaning tao, okay, there are no controlled studies or enough or adequate number of studies to prove that claim. Pregnancy risk category C naman. Animal reproduction studies have shown an adverse effect to the fetus. However, there are no adequate or well-controlled studies among humans, but potential benefits might warrant the use of the drug among pregnant women despite the potential risk. So wala pang napatunayan that this harms pregnant women. However, among animals, meron ng mga evidence that there are adverse effects for fetal delivery. However, they are still weighing the cons and pros of taking that particular drug, and by all means, if the pros outweighs the cons, then we can administer the drug. Pregnancy risk category D, on the other hand, meron ng positive risk for fetal development among human beings. There are evidences that there are adverse reactions based from data from investigations and marketing experience or studies among humans. However, still the potential benefits might outweigh the risk. That's why we are allowing the administration of these medications, however, on a restricted or on a regulated and controlled environment. Ibig sabihin, every now and then you are checking the risk or the drug serum concentration of these patients taking these medications. Last will be your pregnancy risk category X. Pag sinabing category X, wag mo nang ibigay sa pregnant client because it is evident that the cons or the contraindications for this medication administration really outweighs the benefits. That's why by all means you are not to administer this among pregnant clients. Now we proceed to the supplements na tinitake ng ating mga pregnant client. Isa-isahin natin sila based from the presentation. Number 1 will be iron. Pag pinag-usapan natin ng iron, the first thing that should come into mind is the concept of your erythrocyte or RBC, where your RBC is made up of hemoglobin. Okay, when we talk about hemoglobin, it gives your RBC the ability to capture oxygen. Kaya importante for oxygenation ang iron. Okay? Hemoglobin carries oxygen from the lungs and the rest of the body in order to oxygenate different tissues. Now, decrease in hemoglobin decreases the oxygen carrying capacity of a particular RBC. For pregnant clients, the required amount is approximately doubled, primarily because hindi na lang ang maternal circulation ang concern, but also you have that guy, okay, or girl, that is developing within the womb that requires blood as well. Basically, your blood volume increases, number of erythrocyte increases, thus the need for an increased iron. Kaya for pregnant clients, usually the required daily allowance is being doubled. The following are the reasons why, aside from an increased maternal circulation or blood, many women start their pregnancy before pa mabuntis, kaka-start pa lang, their iron stocks or iron stores are insufficient. That's why we need to supplement iron among this client. Number 3, it is an important component of myoglobin. Sir, myoglobin, ibig sabihin muscles? Yes, pero hindi sa nanay. You need to understand that you are developing a human being within the pregnant client's body, which will require organogenesis, meaning nagde-develop ng mga body parts. And in order to adequately develop that myoglobin and collagen para ma-form ang tissues and muscles, you need to have enough supply of iron. And last, in order to maintain a healthy immune system on both the part of the mother and the child. Despite this, I would like you to understand that supplementation is not necessary during the first and second trimester. Madalas ginagawa ito sa third trimester. During the third trimester, definitely, that will be the time where there will be a greater demand for iron, primarily because that is the time. Past, past 24 weeks age of gestation. That's why most of the organs are being formed. There will be an increase in size and weight and development of the fetus. That's why increased demand for iron is required for your client. I need you to understand that iron, okay, maternal iron supplication is not for the child, well, majority not for the developing fetus, but more on the requirements by the mother. So, gaano ba karami ang required amount of iron needed for you to provide to your patients? For non-pregnant client, usually the recommended daily allowance is 18 milligrams. However, it is simply being multiplied more than 2 or according to our PowerPoint presentation for pregnant non-anemic. Ibig sabihin, walang problema sa RBC yung client mo. Usually, the recommended daily allowance is 60 milligrams. However, for pregnant clients who are identified to be anemic in nature, okay, sila pinagtitake ng amount na 120 milligrams. Intake of iron supplements should be continued up until 6 weeks postpartum, primarily to cope up with the loss or the blood loss during fetal delivery. Next will be folic acid. Pag pinag-usapan natin ang folic acid, we are talking about vitamin B9 or folate. Okay, this is basically responsible for the production and maintenance of your new cells. Kaya ang concern natin sa pag-supplement ng folic acid will be primarily for us to have a well-developed fetus during fetal delivery. Ibig sabihin, Bakit? Basically, folic acid deficiency is associated to the following effects. Number 1 is spontaneous abortion. Bigla ka na lang nawawalan ng baby, nawawala yung kapit ng placenta, thus there is imminent delivery of fetus or products of conception without the proper time. Kaya nagkakaroon ng spontaneous delivery. You also have your neural tube defects. These are the improper formation of your different components of your nervous system. Examples of which is spina bifida and anencephaly. Also, you have their small for gestational age. Ibig sabihin, for the age of gestation, the weight, the size of the fetus is too small, primarily because of the lack of folic acid, and abruptio placenta, an untimely separation of your placenta to the uterus that might warrant an emergency to your pregnant client, both maternal and fetal. Kasi nagkakaroon ng internal bleed or what you call hemorrhage. That's why supplementation of folic acid is necessary for your pregnant client. The following are the considerations for administering folic acid among pregnant clients. Well, if your clients had, una muna tayo sa normal. For normal clients, non-pregnant client, usually the folic acid RDA or recommended daily allowance will be 180 micrograms. For pregnant clients, the recommended daily allowance will be 400 micrograms for non-anemic clients. For pregnant anemic clients, on the other hand, the recommended daily allowance is being doubled, 800 micrograms. However, there are special considerations when it comes to the administration of your folic acid, especially for pregnant women who had deliveries or pregnancies that were diagnosed to have neural tube defects. They are to take 4 milligrams, meaning 4,000 micrograms, 3 months before they even conceive the child in preparation for the fetal conception. And they are to take this up until the 12 weeks of pregnancy. This reduces the chance, according to studies, that neural tube defects will occur by 70%. Kaya kailangan. Also, if your pregnant woman is carrying multiple babies, ibig sabihin twins, triplets, and so on, usually they are being prescribed to take 1,000 microgram or 1 milligram of folic acid. The following are the side effects for taking folic acid: abdominal cramps, diarrhea, nausea, sleep problems, irritability, and confusion. However, this is a warning. You need to call right away your prescribing physician once you have experienced skin rashes, itching, redness, or even difficulty in breathing, because these are signs or symptoms that might indicate allergy to that particular medication. So let's now move to your multivitamins by tackling muna tayo sa vitamin A. When we talk about vitamin A or different vitamins, you need to remember the acronym ADEK, wherein vitamin A, D, E, and K are all lipid soluble. Ergo, it alters or affects your liver function. Kasi related sa fat soluble kasi sila. That's why vitamin A is considered to be fat soluble vitamin. Also, its pregnancy risk category varies per or based from the amount of medication you are administering to your client. If you are administering less than 800 micrograms RAE or retinol activity equivalent, the vitamin A is considered pregnancy risk category A. Ibig sabihin, okay na okay. Pero pag more than 800, usually it traverses going to pregnancy risk category C. Medyo harmful. However, it might be administered in a case that the benefit might outweigh the contraindications. However, a particular brand or a particular preparation, namely Aquasol, is considered to be pregnancy risk category. So what exactly are the benefits of vitamin A? umpisahan natin sa benefit among your fetus or sa fetal development. It is important for organogenesis, particularly for the development of the lungs, the heart, the kidneys, the eyes, the bones, even the entire circulatory system. You have your respite as well as nervous system. For the maternal side naman, it helps with postpartum tissue repair because there will be tearing pagka nagkaroon ng fetal delivery, expulsion of the placenta. In order to regenerate that damaged tissue, you need vitamin A. So, ano ba ang dosage ng vitamin A natin? For pregnant women age 18 younger, usually they are required to take 750 micrograms RAE per day. For pregnant women age 19 above, they are prescribed with 770 micrograms REA per day. For breastfeeding women na hindi naman nabuntis, nag-deliver na, usually they are advised to take in 120 micrograms of vitamin A, primarily to facilitate tissue repair. And for non-pregnant client, 700 micrograms REA will be enough. The following are your nursing responsibilities you need to secure when you are administering or prescribing vitamin A for your pregnant client. Number 1, you are to take only what is prescribed, particularly during the first trimester. Also, check the label for any possibilities of toxicity or excessiveness. Why? It is important for you not to take excessive amounts, primarily because, again, it traverses going to pregnancy risk category C kapag tumataas ang dosages, because excessive consumption of vitamin A will lead to liver toxicity. Why? Because, again, it's included doon sa ating acronym na ADEC. Also, it can cause, according to study, fetal bone malformation, cleft palate and cleft lip, as well as renal and eye anomalies. Next will be vitamin D. ADEC pa rin. Okay? This is considered a pregnancy risk category B drug. Pag pinag-usapan ang vitamin D, you always associate that to calcium and bones. That's why it's associated to calcium being associated to phosphorus. Magkakadikit lahat yung concept ng mga yan. That's why vitamin D is important for the development of a strong bone. Deficiency, on the other hand, decreases fetal bone density and weak dental enamel among our pregnant clients. Calcium is vital for electrolyte contractility of your cardiac muscle. That's why you need to understand the need for vitamin D. However, excessive vitamin D, or on the other hand, increases calcium utilization, thus will result to cardiac defects. I would like to share this to you at this juncture of discussion. I have handled patients who are multigravid, grand multigravid. Ibig sabihin, mga patient that are gravida 10, meaning they have had more than 10 pregnancies. I have observed that their dental presentation, usually they only have 2 to 3 teeth remaining intact sa kanilang oral cavity. Primarily because I need you to understand that during the pregnancy period, the body does not care where will it take that calcium, where will it take that vitamin D in order to support the developing fetus. To the point that it takes the stores or it takes calcium from your teeth, from your bones. That's why female are basically at risk for developing osteoporosis kasi bumababa ang bone density because during pregnancy, kinukuha ang calcium stores sa ating bones. Well, based from my story, also on the pregnant client's teeth, pwedeng kunin ang calcium storage. The recommended daily allowance for this particular vitamin is 10 microgram per day. What are your nursing responsibilities with regards to using or administering vitamin D? Number 1, you need to understand that the maximum dose you can give to a pregnant client is 25 micrograms per day. You are to advise the intake of vitamin D, number 1, for patients who are complete vegetarians, Number 2, for patients who are non-drinker of vitamin D fortified milk. Number 3, dun sa mga taong hindi nasisilawan ng araw or nasisinagan ng araw, primarily because sunlight activates vitamin D. Alright? So that is basically vitamin D and its nursing responsibility. Punta naman tayo sa vitamin E, Myra E, so that your mothers will be glowing. Well, that might have a relation to that. However, I need you to understand first that vitamin E is pregnancy risk category A-OK for your mothers. Also, it's considered to be fat-soluble, ADEC, andun pa rin siya. It's considered to be an antioxidant. Well, vitamin E deficiency is very rare. Usually, it's related to an experience of excessive hunger or excessive diet because dietary deficiency is less likely to happen. Extreme conditions na lang to. This is more common if there is fat absorption anomaly. Ibig sabihin, meron namang vitamin E, pero dahil may abnormality ka when it comes to absorption of fat components, vitamin E being a fat-soluble or fat-based vitamins, hindi na-absorb ng katawan. Kaya nagkakaroon ng deficiency of which. However, insufficiency of vitamin E are associated to preeclampsia or an untimely increase or an increase in blood pressure related to pregnancy. Also, patients having fetus small for gestational age. Low vitamin E is also proportional to iron. Okay? Other uses of vitamin E. Women also take vitamin E for premenstrual syndrome, dysmenorrhea, menopausal syndrome, even hot flushes and prevention of breast CA. I need you to understand that vitamin E together with iron is important for developing erythrocytes, muscles, and other tissues. Supplementation of which is not advised though primarily because of the presence of different dietary supplements. Also, if ever you are to supplement vitamin E among your pregnant client, never ever provide vitamin E together with vitamin C according to the prescription or the advice of WHO. The recommended daily allowance for vitamin E is 10 milligrams per day. Now that I have mentioned vitamin C, punta na tayo sa una nating water-soluble vitamin, which is basically your vitamin C. This is considered to be a pregnancy risk category A. However, if it exceeds or more than the recommended daily allowance, it might traverse to pregnancy risk category C. Bakit? Malalaman natin mamaya. The purposes of vitamin C is basically for tissue repair and production of neurotransmitter, especially for the developing fetus. The enzymatic action for activation of the immune system is being facilitated by vitamin C. That's why when we talk about vitamin C, ang unang pumapasok sa ating isipan will be immunity. This is also considered to be a water-soluble antioxidant. That's why it's necessary to be given among our pregnant clients. But what exactly happens when there is vitamin C deficiency? Number 1, vitamin C deficiency is associated to preterm birth. Ibig sabihin, hindi pa term, lumalabas na yung baby, less than 36 weeks, 38 weeks of age of gestation. This is also associated to PROM or premature rupture of membrane. Hindi pa dapat pumutok yung amniotic sac, pumutok. And you will understand as we further our discussion with regards to the effects or to the benefits or importance of your amniotic fluid and amniotic sac. Also, it is associated with pregnancy-induced hypertension or PIH or eclampsia, preeclampsia. However, excessive intake might lead to rebound scurvy and muscle weakness, capillary hemorrhage, as well as progressive demise of the fetus. That's why you should not exceed on the recommended daily allowance provided, which is 70 milligrams. Again, reminding everyone that vitamin C and vitamin E should not be taken together. Now we move to your vitamin B complex by, tackling one by one kung ano bang component ng vitamin B complex aside from folic acid. Nandyan ang vitamin B1, which is your thiamine. It is important for the metabolism of your carbs and proteins. Thus, it is required for energy production. Necessary for pregnant client because, again, you are developing fetus within the uterus. Deficiency of which might lead to what you call a condition beriberi. The recommended daily allowance is 1.5 milligrams. Next is B2 or what you call riboflavin. Your riboflavin is basically involved for the catabolism, breakdown naman ng fatty acids. Deficiency of which might lead to chelosis or cracking of the lips, glossitosis, ibig sabihin na mamaga ang dila, dermatitis, and even anemia. The recommended daily allowance for vitamin B2 is 1.5 milligram. B6 naman ang pag-usapan natin, which is basically your pyroxidine. This is necessary because enzyme needed for amino acid metabolism and biosynthesis of different neurotransmitter, contributory ang B6 natin. Deficiency of which now is associated to neurological symptoms, examples of which is epilepsy and seizure, also associated with dermatitis and anemia. Excessive intake, on the other hand, might lead to improper gait or gait disturbances as well as sensory neuropathy. The recommended daily allowance for this particular medication is 2.1 milligram. Next will be vitamin B12 or your cyanocobalamin, which is responsible for metabolism of all of your carbs, proteins, and fats. Also, it's responsible for the production of new cells in your bone marrow. Thus, it serves as building block for your new developed RBCs, required for the increase in blood volume among our pregnant clients. Next will be calcium in relation to vitamin D. Calcium is considered to be pregnancy risk category C, as in calcium. The baby will do anything, as what was explained a while ago, in order to acquire adequate amount of calcium, including stealing from different body areas or anatomical landmarks of your pregnant women's body. Examples, kagaya ng nasabi kanina, will be your teeth as well as bones. That's why you need to have adequate amount of calcium. However, you need to keep watch on how much calcium you are providing your clients, because calcium has the following effects. It keeps, it is needed for skeletal mineralization, particularly on the third trimester. It keeps your blood and muscles moving because your calcium, enables different blood vessels as well as muscles to contract. It helps to propel electricity during neural impulses. That's why it's important for the developing fetus and the maternal circulation as well. You need to understand that your body or the pregnant woman's body can only absorb as much as 500 milligrams of calcium in one intake. And also, too much calcium might lead to excessive contraction of your gastrointestinal system, leading to stuck or blocking the normal flow of your food or your peristaltic movement, ergo constipation. It increases the risk also for developing kidney stone formation. Kaya, calcium should be regulated and should be given properly on a designated amount. It might also hinder both the absorption of iron and zinc. Maternal deficiency, on the other hand, is associated to poor maternal and fetal bone density as well as pregnancy-induced hypertension. The recommended daily allowance for calcium is 120 milligrams. We have talked about your vitamin D, kaya pinag-usapan din natin ang calcium. Also, trio yan. Dapat palaging nakasama ang phosphorus. Phosphorus is needed or is an important component of DNA and RNA as well as phospholipids. The balance between calcium and phosphorus should be achieved in order to acquire optimum bone integrity. Kaya dapat balanse. Phosphorus is rarely found inadequate, and usually it is a result of extreme starvation or diet. It is important for proper development of fetal bone. That's why, again, balance between calcium, phosphorus, and vitamin D is necessary. Phosphorus is needed in order to maintain maternal health because it basically regulates the different metabolical processes within your body. deficiency of which is related to the deficiency being felt sa calcium as well as vitamin D. It has something to do with bones and the bone density. The recommended daily allowance for phosphorus is also 1,200 milligrams. Together with calcium and phosphorus, all these electrolytes, kailangan din natin ng magnesium. At this juncture of our discussion, because they are supplementals, we will not be tackling in depth kung ano ang magnesium. However, if we go further all throughout our discussion, as we go further sa ating discussion sa handout na to, you will understand more regarding the importance of magnesium sulfate and its relation to pregnancy. However, I need you to understand that if calcium contracts, magnesium relaxes. Kaya nga meron tayong mga magnesium foot baths in order to relax the body. Studies show that adequate magnesium level prevents premature uterine contraction. Mamaya maintindihan pa natin to. Magnesium and calcium works together hand in hand. Despite their contradictory effects, they need to be in harmony or balance. Deficiency in magnesium might result to nausea, vomiting, loss of appetite, fatigue, insomnia, muscle twitching kasi hindi nagre-relax, poor memory, and even irregular heartbeat because this regulates together with calcium ang pagtibok ng ating puso. Okay? The recommended daily allowance of your magnesium is 320 milligrams. Last among our supplements will be zinc. Hindi kompleto from A to zinc. That's why zinc is needed for cell growth and DNA production, especially for fetus and fetal development. It is important to take extra for those that are vegetarian and diabetic, primarily because of their poor diet and absorption. Side effect associated with intake of zinc is nausea, vomiting, abdominal cramps, and even diarrhea. Excessive intake, on the other hand, might result to prematurity or stillbirth, deficiency of which is associated to high fetal mortality and even malformation or malfunction in terms of organogenesis. That's why you need to take extra precaution in supplementing your zinc. Now we proceed to the medications or drugs that are being provided in relation to the normal discomforts that pregnant women feels all throughout the duration of your pregnancy. We have 3 identified normal discomforts: nausea and vomiting, heartburn, and even pain. Let's start with nausea and vomiting. During pregnancy, we need to maintain an elevated level of progesterone to sustain the thickening of the layer of your uterus. That is based from your concept of anatomy and physiology. However, hindi naman palaging dapat nagsisekret ng luteinizing hormone para yung ovaries mo magsekret ng progesterone and estrogen. Hindi pwede. Kaya ang ginawa ng katawan, there is now this what you call human chorionic gonadotropin that will stimulate your corpus luteum that was fertilized, okay, to always produce ang ating progesterone in order to maintain progesterone. However, I need you to understand that due to the presence of this human chorionic gonadotropin, 88% of women who are pregnant experiences nausea and vomiting. Kaya pag nanonood ka ng telenovela, especially here in the Philippines, usually a sign of pregnancy will be morning sickness or nausea and vomiting. That's normal because of the presence of HCG. What is abnormal is for this repetitive feeling of being nauseated remain untreated, and it might progress to what you call hyperemesis gravidarum. Sobrang pagsusuka during pregnancy. That is the literal translation of hyperemesis gravidarum. If left untreated, it might result to severe dehydration. That's why you need to understand our responsibilities and interventions when it comes to treating morning sickness or nausea and vomiting. Punta muna tayo sa non-pharmacologic treatment for nausea and vomiting. Number 1 is dietary alteration. Basically, brat diet, bread, rice, and toast. Walang masyadong seasoned food and fatty food in order to promote gastric rest. Next will be for you to employ SFF, or what you call small frequent feeding. We would not like to bombard or to load your gastrointestinal system so much by eating a buffet during the time na ikaw ay pregnant, primarily because consider, ang normal na tao, ito ang katawan. Nabuntis ka, there is a developing fetus within you that will compress other body parts that will include your gastrointestinal system, thus might revert to a reverse peristalsis resulting to a feeling of nauseated, ending, baka ikaw ay mag-vomit. Also, smoking cessation might lead or might stop giving you the feeling of being nauseated, and also taking those medications that causes nausea and vomiting at bedtime usually. Now, if being nauseated is being caused by the intake of iron, then temporary suspend iron supplication. Take multivitamins at times that are, well, hindi morning, because usually morning sickness or being nauseated is associated sa umaga. That's why pick another time where you are to take your oral medications or oral supplements. Enough salting of food might be helpful to increase electrolyte balance. Comes the time na nagva-vomit ang pasyente mo. Siyempre, sumasama ang gastric contents together with fluids and electrolytes. That's why in order to replenish your electrolytes, you might want to season your food a little bit better. Also, taking foods rich in magnesium and potassium, all your electrolytes might be necessary. If one is experiencing severe fluid loss, dehydration, or weight loss, IV rehydration might be necessary in the event of a hyperemesis gravidarum. The antiemetic of choice among our pregnant client will be Magnesium hydrochloride. The site of absorption is basically the labyrinth of your central nervous system that blocks the chemoreceptor trigger zone, or the CTZ, which is basically responsible it controls your vomiting center of the body. This is considered to be pregnancy risk category category B, contraindications of which will be hypersensitivity to the particular medication. Side effects of taking Magnesium hydrochloride is also flashed in the PowerPoint. However, cardiovascular effect might happen. This is a special consideration which might include hypotension, palpitation, and even tachycardia. Warning and precaution for pregnant clients or patients who are suffering from closed-angle glaucoma. Next will be our concern for heartburn. Mind you, despite the word being heartburn, this is not associated to your cardiovascular system, but rather to your gastrointestinal system. This is also known as pyrosis, a burning sensation on the gastric region or the gastric part of your gastrointestinal system. Okay, the burning sensation is usually felt in the epigastric portion, usually generalized on the epigastric portion of your abdomen. However, at times more of the left side, primarily because of the presence of your anatomical landmark, which is your cardiac sphincter. Ano bang nangyayari? There is a reverse peristalsis. Why? Because of the presence of an elevated progesterone, brought about again by the presence of your human chorionic gonadotropin, all of which is necessary for maintaining the integrity of your uterus to support the growing fetus and placenta. Progesterone basically relaxes your cardiac sphincter. Dapat nakasara yung cardiac sphincter mo, but because of progesterone, it loses the tension in that particular site. Thus, reverse peristalsis happens, wherein the gastric contents reverts back towards your esophagus, having a highly acidic content in your gastric area that might injure your esophagus, ergo the sensation of pain, thus heartburn. The non-pharmacologic relief for heartburn or pyrosis are the following. Una, wag mong i-bombard, wag ka mag-buffet so that hindi ka magkakaroon ng reverse peristalsis. Meron na nga progesterone that relaxes your cardiac sphincter, tapos sinamahan mo pa ng buffet, lumalaki yung baby. So what the tendency is, the growing fetus will push that part of your gastrointestinal system back towards to where it came from. Kaya tendency, heartburn, and even nausea and vomiting. Avoid highly seasoned food, fried foods, greasy food. Avoid gas-forming food, and chill ka lang sa pagkain. Eat slowly and chew well. The pharmacologic relief, however, will be the administration of non-systemic low-sodium products containing aluminum and magnesium, common Philippine setting Gaviscon. Addition of simeticon might be necessary in order to have an anti-flatulence kontra-otot effect that promotes gastric bubble expulsion. Common drugs associated with heartburn will be aluminum hydroxide and magnesium hydroxide, both of which are considered to be pregnancy risk category C. Okay? Information about these drugs are flashed on the screen. However, I need you to understand that the major difference between aluminum and magnesium is the presence of an anti-flatulence effect on the magnesium side. And last among our normal discomfort will be pain. Pag pinag-usapan natin ang pain before the 26-week period, okay, usually that is brought about by hormonal changes among our pregnant clients. Okay, that is associated with emotional, hormonal, sinus congestion, and even eye strains. However, for AOG or age of gestation more than 26 weeks, probably because of the developing fetus, the pain is associated to back pain, joint pain, pains, ligaments, primarily because there is an increased size and weight of the fetus. Now, for the non-pharmacologic relief of pain, always remember P2 fire. What is P2 fire? Postural changes and proper body mechanics when moving. That's why there is what you call your pride of pregnancy, a little bit lordotic in order to control their center of gravity. Footwear changes might be necessary. Letter I, ice pack or warm packs sa mga areas that are in pain, primarily because you are carrying additional weight on your abdominal area. Also for R&E, rest and exercise. The common medication provided to our pregnant client is your acetaminophen, pregnancy risk category B. For acetaminophen, it can be used all throughout the trimesters. It has a short-term relief for pain. However, it does not have any anti-inflammatory effect. It causes the placenta easily because it's considered to be low protein bound, 20 to 50%. It can also be found in low concentration in breast milk for breastfeeding clients. However, no studies have been found that it might harm the child or the newborn that is taking milk from her mother. Side effect of acetaminophen, well, clients that are hypersensitive to this medication do not give acetaminophen. Use with caution for high risk of infection, for it might mask symptoms of infection. Kasi usually infection is being characterized by pain. If you are to give acetaminophen, it might mask pain. So baka meron na palang infection na nangyayari sa fetus or within the placenta due to a breakage of that barrier of that amniotic sac. Okay, amniotic fluid might have escaped all throughout. That might lead to an increased risk for infection for the fetus developing within the body. Okay, that might mask the symptom. That's why extra care when administering acetaminophen for patients who have suffered premature rupture of membrane. Skin eruptions, urticaria, bruising, erythema, hypoglycemia, jaundice, anemia, neutropenia, leukopenia, pancytopenia, and thrombocytopenia are some of the side effects or adverse effects of taking acetaminophen. The maximum dose of acetaminophen is 325 milligrams per tab per capsule, usually given in an interval of every 2 hours or maximum dose of 12 doses a day. However, if it's extra strong dose, 500 milligrams per tab or per capsule is usually given every 3 hours at most. Kasi maximum dose is 8 provisions per day. However, usually the common intervals for taking acetaminophen is 4 to 6 hours. In case of an acetaminophen toxicity or excessive intake or overdose, the antidote of choice is N-acetylcysteine. Also, if you are experiencing liver toxicity brought about by acetaminophen, you are to take glutathione, which is basically a liver protectant, because glutathione prevents alcohol that converts acetaminophen to hepatotoxic uh, to its hepatotoxic byproducts, meaning acetaminophen, strictly speaking, is hepatotoxic in nature, especially if taken in excessive amount. That's why you need to take glutathione in the event that there might be excessive intake of acetaminophen. Next will be aspirin, another famous drug when experiencing fever. Aspirin is basically pregnancy risk category C. However, if taken in full dose, might be considered pregnancy risk category D. It has an analgesic, antipyretic, anti-inflammatory effect. However, it can inhibit initiation of labor that might result to prolonged labor, which at times will be prescribed while other times will not be recommended. Use in the latter portion of pregnancy might increase the risk for maternal bleeding due to delivery. Primarily because aspirin is considered to be an antithrombotic. Ibig sabihin, tinatanggal niya ang pagbind or the capability to form a clot. Therefore, there is an increased risk for anemia and postpartum hemorrhage, especially if aspirin is taken during the last trimester of pregnancy. Also, infant are being affected. Problem with hemostasis. Ingestion for the last 2 months of pregnancy might cause irreversible bleeding abnormalities among infants. That's why, as much as possible, our drug of choice for pain will be acetaminophen and not aspirin. However, if prescribed by cardiologist, extra precaution when taking aspirin, especially during the latter portion or the third trimester of the pregnancy. Let's now proceed to medications that are being used to treat what you call preterm labor. Ano nga ba preterm labor? It's basically an experience of being in labor during the 20th to 37th week before the term period and the age of viability, which is 20 weeks. Or, if we will base it from the weight, 500 to 2,500 grams. Basically, we are assuming that at the age of 20 or at a weight of 500 grams, a patient or a baby can already survive outside of the mother's womb. Well, what happens in preterm labor is there will be an experience of strong contractions accompanied by a dilation or enough to cause a dilation with a length or 2 cm dilation and 80% effacement. Ano ba yung kaibahan ng effacement at saka dilation? Based from your maternal and child, dilation is basically the increase in the opening of your cervical area, and your effacement is the thinning of that film that guards that particular area. Now, the goal for treatment for preterm labor is for us to prolong pregnancy kasi wala pa sa tamang panahon. Kaya dapat natin siyang i-prolong until full organogenesis has occurred. The following are risk factors when it comes to preterm labor. If the maternal age is below 16 or even above 35, so extreme ages, madalas nagkakaroon tayo ng preterm labor. Low socioeconomic status, previous preterm labor, uterine infection, excessive amount of amniotic fluid, maternal sepsis or infection, multiple gestation, masyadong marami yung baby, uterine anomalies, hemorrhage, even smoking, and UTI. All of the following are contributory according to multiple studies when it comes to preterm labor. As stated a while ago, preterm labor, the goal is to prolong pregnancy. However, not all the time when there are labor or the patient is experiencing labor contractions, we should stop it. Kailan natin siya pipigilan? That is the question. Number 1, if the age of gestation is less than 20. Because in the first place, it's not viable enough to live. That's why just let the product of conception flow through your patient, because in the first place, you cannot make it live according to science. PROM or premature rupture of membrane. Bakit ayaw natin i-prolong ang delivery? Primarily because when the membrane has been ruptured, you're like a ticking bomb with a time of 24 hours. Why? Because there is an increased chance for infection that is so severe that might cause not only the loss of life of the fetus but also might jeopardize your maternal's health or even life. Confirmed fetal death or incompatible life, as what was explained in relation to AOG. Maternal hemorrhage, excessive bleeding brought about by contraction. Kailangan nang ilabas yung fetus despite its age, primarily because a prolonged experience in maternal hemorrhage might cause may result to hemorrhagic shock due to a significant decrease in circulatory volume. Next is fetal compromise or distress. Pag ibig sabihin, imminent na yung death ng bata during contraction, well then by all means, you might terminate the pregnancy or prolonged labor might be contraindicated. Severe PIH, because we associate PIH that the only reason or the only way for us to relieve a patient from PIH is the delivery of the products of conception. Kaya nga siya tinawag na pregnancy-induced, only pregnancy-induced hypertension. Also, if there is a progress wherein the dilation progress to 4 centimeters and effacement of 50%, imminent delivery na to, hindi na mapapahinto. And also infection of the chorion or what you call chorioamnionitis.